And welcome, everyone. Tonight, this is Sue Vogan, and I have with me Dr. Levin. And we also have a wonderful guest tonight, Dr. Lipson, Mindy Beth Lipson. She was trained in the San Francisco Bay Area with a doctorate in clinical psychology from the Wright Institute at Berkeley. She's worked in the clinical health fields for over 10 years in extremely diverse areas, such as medical health, trauma, chronic mental illness, addiction, grief, stress, domestic violence, sexual offenses, relationship issues, child, adolescent, and adult development, and self-actualization. Her training has provided her with excellent opportunities to provide traditional, eclectic approaches, as well as newer, more innovative, and holistic healing techniques, such as energy psychology. She is interested in the emotional effects of tick-borne diseases and is currently working on research, which she plans to publish in a book discussing this fascinating, cutting-edge topic. Dr. Lipson works with many holistic, diverse health professionals in the greater United States to provide excellent services to those she serves. She is adept and intuitive in helping those she serves to find their way to healing when faced with difficult medical conditions or challenging life circumstances. Dr. Lipson is also a Lyme literate psychologist, writer, activist, and a member of the American Psychological Association. Welcome to In Short Order, Dr. Lipson.
Thank you so much for having me on.
Hi, Dr. Levin.
Hi, Sue Vogan.
Well, let's get started. I guess I can ask the first question. We can kind of go from there. We're going to talk about the emotional effects of Lyme disease and healing, too. What are you seeing in your practice with regards to emotional Lyme, Dr. Lipson?
Well, I think that's a huge question. It might take the whole 2 hours, but I'll try to be brief to answer the question. I think that, Lyme patients really are dealing with so many issues, and I think the first part is because of a lot of the controversy surrounding the illness. And so I think that there's sometimes, because of misdiagnosis or underdiagnosis, patients will end up going from doctor to doctor for years and years and years, and oftentimes when they come to my office, they may have already been told either that they have another type of illness, which isn't a cause, it's just like a label, or they're just told that they're depressed and they need medication, and they'll feel at the time when they see me that they don't know really what's going on. They know that there's something wrong with their body, but they don't know how to get anyone to listen to them. So I think the first part is the difficulty in diagnosis, and so that causes its own stressor, and I think there's a lot of trauma involved in that.
Right. How do physicians, and maybe Dr. Levin could answer that, whenever a patient comes in and they have this emotional stress from Lyme disease, what's the doctor supposed to look for? What can he look for, or she look for?
Well, I think Mindy's certainly correct. People who are in the process of being misdiagnosed, they are actually calling this a psychosis now. The Infectious Disease Society of America is calling it an artificial diagnosis psychosis. And it is a terrible illness to begin with, and people with chronic pain are depressed, and people who are chronically fatigued are depressed. And I think it's also important to mention that there are psychiatric manifestations of Lyme disease as a result of the organism being in the brain. It's called neuroborreliosis. And in spite of the IDSA, one of the past presidents of the American Psychiatric Association, Dr. Paul Fink, basically said that every practitioner who is making the diagnosis of a neurosis or psychosis or obsessive-compulsive disorder should consider the possibility that Lyme is playing a role in the process. It's not being done, but that's an important issue.
Yeah, I think that's so important that, we really think about that. And I think a lot of times in my field, in psychology, and also in the field of social work or other mental health providers, that's not something that's really discussed. So it's really a paradigm shift because we were trained, these are the labels, this is what you look for. And then there's this other, group of people that are trying to grow and look in a new way, which is to understand that there's these neurochemical changes that are happening in the brain from infectious organisms, whether it's Lyme disease or other infections, whether they're tick-borne or they may be just a strep infection, and then that's causing symptoms in the brain that may look like these labels that we used to just say, this is what you look for, and now it's a paradigm shift, and I think a lot of clinicians need to be trained to understand that.
I certainly agree with that, and especially in the kids, we have this PANDAS diagnosis, which is from strep, and kids have a lot more strep than adults do. So that can be another cause for really disruptive behavior and defiant behavior and obsessive compulsive stuff. It's called PANDAS, and fortunately it usually responds to an intensive antibiotic program.
Dr. Lipson, you and I talked briefly before the show and one other time. We're seeing a lot of, people that have Lyme that are doing things out of the ordinary or saying things out of the ordinary. And I know I'm guilty of that once in a while, saying things that I don't know where that came from. What are you seeing any of that in your practice as well?
Yeah, I think that when somebody's brain has been affected by an organism, it's causing these neurochemical changes, and even a simple thing as, being sensitive to light or sound could make somebody extremely irritable. And so I think that can cause, even a simple thing as that could cause such irritability in somebody where it may appear as if they're, of not wanting to look at you, or so I think that can cause personality changes, just that simple thing. But there's so many other things that happen from the illness.
Right.
Hypersensitivity is characteristic, and there are all kinds of sensations that are intolerable to people that usually had no problem, from driving at night to a shower being painful. And all of this certainly produces a patient who's going to have psychiatric symptoms, even if it isn't from the infection itself.
So doctors are to look for what now? Should they consider that an infection, should that be on the top of the list when patients present?
Well, I think it really just depends, first of all, on when you're, the difference between the way medicine used to be practiced and the way psychology used to be practiced is that usually in psychology we spend a lot of time with people. So when we meet with them, we're spending, over an hour at a time, sometimes like between 50 to 60 minutes, and sometimes in the first session around 90 minutes. And so over weeks and weeks of meeting with somebody, you get a picture of their life, and you may hear things, and you have to start to ask the right questions. So I think, first of all, in an endemic area, and of course Lyme disease can be all over the country, all over the world, but in an endemic area, if you know that somebody is doing activities like, they're hunting or they're fishing or they're camping, or they mentioned that they had a tick bite years ago and it was never treated, or it was treated for a brief time, or they have family members with Lyme disease, or, I think it's sort of about the way that you ask questions. So if somebody comes into your office with depression, we may ask, specific things about their sleep and their appetite, but with Lyme disease, if you think that they may have been exposed, you need to ask other types of questions to see that. And then at that point, if you feel like there is something and they were maybe misdiagnosed, then at this point I would refer them to a Lyme literate doctor who could, further evaluate them.
Right.
My point is so frequently whether the patients present with neurological illnesses such as, well, they've been diagnosed with multiple sclerosis or polyneuropathy or even ALS, Lou Gehrig's disease. Multiple sclerosis and Lou Gehrig's disease have such a poor prognosis that it seems to me, since some of these patients have been shown to have Lyme disease, and we can't say that the Lyme is the cause, but it certainly can be aggravating, and there are patients who have been turned around with intensive antibiotic therapy. So those patients, I think, should be tested for Lyme and other infectious diseases, because that offers the best hope if you can find it. Dr. Martin in Colorado came down with ALS himself and was diagnosed with Lyme and Babesia. And with aggressive treatment, he was able to return to practice and has been seeing patients with ALS now, so that there is some hope. And psychotic breakdowns in this country are treated with drugs. It's sometimes necessary to drug a psychotic patient to prevent him from injuring himself or others. And certainly we don't have the insane asylums anymore that we did when I was in training. Thousands of people living in horrendous circumstances. Snake pits, they used to call it. And it was because they had nothing to offer until the drugs came out. And Thorazine was the first successful one. But still, these drugs don't make healthy people. They make them able to live outside of an insane asylum. Some of them function at various jobs, but the drugs are not fixing the problems.
Absolutely. You know, this reminds me of a story from when I was working many years ago. I was working for a crisis team in New York City, and there was a client that we had gone out. We were doing like home visits, and there was a client that we had gone out to see on multiple occasions, and I was convinced that this patient that I was seeing had Lyme disease based on the history that I was taking and speaking with the mother. At age 15, he was working in construction, and he had had a tick bite on him, and ever since then his behavior had been extremely manic, and he had been psychotic, and he was hospitalized like multiple times, and he had been seen by this crisis team previous to me like about 25 times. And I had written a letter to one of the psychiatrists when we tried to triage or tried to bring him to the for hospitalization. When they did the triage, they dismissed it and they sent him to another hospital. Then again, I tried on multiple occasions to get this patient to be seen, and he was also very socioeconomically disadvantaged. And I think this is also one of the issues, is that for people who are coming from, you know, lower socioeconomic strata, or they don't have knowledge, or they don't have doctors who would advocate for them, they kind of get stuck into this problem where they're treated for, and again, this man was hospitalized multiple times for psychotic behavior, yet this was from Lyme disease.
Wow. What about metal toxicity? Could that play a part in any of this emotional? Because we find that a lot, do we not, in Lyme patients, or actually in patients? Could that
well, I think we find it in anybody we look for it in this country. To some degree, we are all seriously polluted, not only with lead and cadmium and mercury and arsenic. Everybody's getting arsenic in their food from the arsenical pesticides. Lead has come down somewhat because of the change.
Right, I think we lost Dr. Levin. Let me check. No, he should still be here. Dr. Levin, are you there? Let's talk more about what you do, Dr. Lipson, in your practice, because I'm fascinated. I really am. What is energy psychology?
Well, it's sort of a broad term for different types of modalities, and one of those would be, of course, the old hypnotherapy, and the newer things are more like EMDR, which is eye movement desensitization and reprocessing, which is a treatment for trauma. And I find actually that it's really helpful for people who have tick-borne illnesses because of the earlier thing I was talking about when clients, come in and they've been either underdiagnosed or misdiagnosed, and their doctors have told them they're just depressed, and they've been, told by so many people it's just in your head, there's nothing wrong. So they do have a lot of trauma, and they hold a lot in their body, not only because of the illness itself, but because of all of the, the stress and the trauma. And so EMDR is a way of working through some of that, the trauma.
Wow. Well, you writing a book, we need more.
That's an ongoing thing.
What kind of things are we going to find in there?
Well, it's really
is it for patients or clinicians?
It's for both. It's really meant for both. It's meant to give clinicians an understanding of what's going on in the lives of Lyme disease patients and their families, but also it's to help Lyme patients to better understand some of the things that are going on for them so that they don't, feel as alienated. They can understand that other people are going through similar things, that the things that are happening to them are normal. Like in terms of the loss that has happened to them, in terms of either their functioning, losing their job, going bankrupt, that these things happen to a lot of Lyme patients and, that they're not alone.
Right. Dr. Levin, do we have you back?
Yeah.
Thank goodness.
I didn't want to subscribe to the Dish Network, but they cut me off.
It happens. I want to let everybody out listening right now, this is our first on live, just really live, blog talk show. So if we have a few little kinks here and there, we're going to work them out, and we hope that you'll be patient. I want to let everyone know this hour of In Short Order is brought to you by Pure Observations Magazine this week. And if you want to call in, we do have a guest call-in number. It's 718-664-9291 if you do have a question. All calls are screened. Okay, you were talking about metals, Dr. Levin, before you left with whoever.
Yes, the lead and mercury, cadmium and arsenic and aluminum are heavy metals that are in everybody's body today in 100 times as much as was in our ancestors' bodies that we've been able to see from hundreds and thousands of years ago. These frozen bodies in the tundra and some of the Egyptian mummies and so forth have been looked at, and their toxic mineral burden was nowhere near what we are carrying.
Right.
And they had more of the essential minerals like calcium, magnesium, zinc, chromium, selenium than we do.
Right.
So it's a problem.
Right. It looks like we have a caller. Let's go ahead and take this call. Let me do this up here. And let me see. Caller, are you there? Hello? It looks like we lost the caller. Okay. Well, yes. I was asking Dr. Lipson while you were on that brief hiatus there about energy psychology. Dr. Lipson, you use a lot of holistic, right, in your treatments? Okay.
Yeah, I mean, I do traditional psychotherapy, but I find that that's somewhat limiting now in terms of the work that I've been doing. So I'm always looking for other types of tools to help people, and I think that's sort of the wave of psychology now. If you don't do that, you're not going to be able to really help people.
Have you used the EFT?
Yes, the EFT is amazing. I love it.
Let's talk about EFT.
Well, EFT is emotional freedom technique. I think a lot of the psychologists are using something called ETFT also, which is evolving thought field therapy, but they're very similar in terms of technique. They use acupressure points and, saying mantras and kind of clearing energy through the body. I find it to be somewhat similar in the body, in terms of releasing from the body the way that EMDR is, which I just mentioned before, which is when you have a trauma, you are holding things in the body, and some people are more body-oriented than others, so it's a way of releasing some of the trauma from the body and to reintegrate and think about things in a more positive way. Are you using EFT in your practice?
Well, I believe in it, but I am not using it. I am limited because I'm spending a lot of time with patients just getting the responses to therapy straightened out and making sure that the co-infections are not showing up late after previous testing, and many of the patients that I see from other doctors who have, we all have failures, and all of us see the failures of our colleagues. We don't see their successes because they stay on when they're being successful.
Right.
So for me, the most common missed diagnosis is not a psychological one. It is the co-infection with Candida. Now, it's not a co-infection. A co-infection is, in Lyme disease circles, is one that is transmitted by the same tick bite as the Lyme disease. But this is a complication therapy without adequate prevention of the overgrowth of the Candida, which eventually can become a very serious problem.
It looks like we have our caller back. I hate to interrupt. Caller, are you there? Hello? Hello? Maybe we just have a wrong number. Keep calling in. Caller, if you're listening, would you please get into the chat room and let me know what your question is, because we can't seem to get your call up. Okay? All right. Where do we go from here? What do clinicians? I mean, is there a form that clinicians look at and say, okay, check the box? Is that might be something that we can change, or how are we going to make the changes?
Are you asking in terms of the way that we see mental illness?
Yes.
Well, I think that part of that is one of the reasons why I'm doing the show and why I continue to try to give talks at different places where either social workers or other psychologists are being trained, because I think that there's a lack of knowledge. And so one of the most important things is to just start to just do grassroots educating, which is what Lyme patients did in the beginning, just to educate other Lyme patients. I think that clinicians have to do that now also. What I've been seeing recently is sort of this, just like there's the controversy in the medical community about what is Lyme disease, that now this is now happening in my field, where there are groups of psychologists who are going back to the old traditional, this is, like Dr. Levin had said, psychosis or somatization, this isn't really an illness, there's something wrong with the patient psychiatrically, and yes, there may be something wrong psychiatrically, but it's from an infection. So there needs to be more education. So I think that's the first step, and understanding that there has to be a paradigm shift happening in psychology and in social work or other mental health practitioners that this isn't just the way you always do things doesn't always work. And you're limiting your patients and you're not helping them if you ignore some of the things that they're telling you.
Right.
I also think, talking about paradigms, our paradigm in the last, third of the last century has been so focused on drugs for symptoms, and there have been major attempts to change the psychiatric approach. It's called orthomolecular, and it's based on a simple notion, which is that the human brain has developed over either thousands or millions of years, depend on what your belief is, but it's in an environment that has been relatively constant, and it is capable of adapting to substances that it's developed with. And we are throwing foreign chemicals into the brain with the notion that we're going to fix it, and we don't know enough about the brain to do that. There's a great quotation from a non-physician named Emerson Pugh, P-U-G-H, who said that if the human brain were simple enough that we could understand it, we would be so simple-minded, that we couldn't understand it. And I think that's absolutely true. I don't think we're ever going to understand the brain in all its complexity. And the idea in particular, I am particularly put off by the psychiatrists who make a diagnosis of ADHD, attention deficit hyperactivity disorder, and the first thing they do is say to the mother, here's this chemical from ABC Pharmaceutical Company. Now, we don't know exactly how it works, but it's helped a lot of people, and it's going to help your child's brain. And I think that's delusional thinking. And it's a standard. One of my colleagues, Mary Ann Block, who's a osteopathic physician, says ADHD really stands for another doctor handing out drugs. So the drug for the diagnosis is really a problem. And there are other ways to do that, and it sounds like Mindy has a arsenal that is really impressive.
Oh, thanks. Yeah, I mean, I think it's sort of the thing that about what you just said, that quote that you just had mentioned. This is something that we've been struggling with as humans for eternity, which is we always think we know everything, and we don't. And it's always a learning curve. So, to say that, this is the answer and this is exactly what is happening, when doctors say this is, Lyme disease is an easily treated, easily caught illness. I mean, that's absolutely preposterous. You can't know everything about something. It just doesn't make any sense. So we're always growing and learning, and I think that part of why working with Lyme patients is so amazing is that they're always teaching you something. You're always learning something new. Like every time you meet with them, it's like, oh, I didn't know about that, and then you're on to the next thing of learning. So I think that that's what makes it so great. Even though it's hard for them, and and it's hard for Lyme patients to have to see them go through what they're going through, but they're also learning so much about themselves in the process.
Well,
I do have a
it is one example, certainly a major example of the big problem in the United States, which is that nobody is dealing with chronic illness from their training. They learn great stuff for emergencies and acute illnesses, but nobody understands the complexity of the chronically ill patient, particularly as they get into the older age group. And you have to look at the adrenals and the thyroid and the ovaries and or testosterone, the failing lung function, the degenerating heart. All this is a huge problem, and our system sends everybody to a different specialist for a different piece of it. And that is a very big part of our problem in this country today.
Yeah, absolutely. And then add to that, a very complex human with spiritual needs and emotional needs and all of these other things that are not getting met, it makes it even worse, because then they're being sent here for this and here for that, and that doesn't leave a place for them to be heard or to be understood. So I think that, healthcare has to evolve now to, be able to provide, their clients with everything in one location, so that they can be treated for their spiritual and their emotional health and their, their cognitive functioning, and then all of those things you just mentioned, all of the other organ systems in the body.
And it's a tough thing to put all in one place.
Yes, it is.
We have these tertiary care centers that have specialists in everything, but they still are not putting anyone in charge of looking over the entire process. At any rate, this is especially about Lyme, and I feel that the diagnosis of Lyme is in such a precarious place because of the basically two views of the disease that are competing, if you will, for priority. And in our society, the bigger numbers get the most votes. But scientific truth is not decided by majority vote. And we are, all of us in ILADS, are fighting not just for the patients, but for the privilege of practicing according to our training and experience. And this is the Infectious Disease Society has taken a very aggressive attitude. They testify against doctors who don't do it their way, and they refuse to examine the evidence even when it's presented in a court of law. That was a pretty amazing thing. So,
are you dealing with that as well, Dr. Lipson?
Well,
controversial part?
I mean, not in the same way, that Dr. Levin is. I mean, I think that he has a much more, intense situation than I do. But the way that I'm dealing with it is in terms of what when clients come to me and they talk about how they either can't get treated, or they don't have money to get treatment, or their insurance company won't pay for their treatment, or somebody told them that it's not Lyme disease. What do? They're confused. They've been to 10 different doctors. They get 10 different answers. So I'm dealing with it more in terms of their internal life, emotionally, how they're coping with all of these things.
Right.
Not, because I'm not a medical doctor, so I don't have to, I'm not dealing with it in that way.
Right. So if a patient presents to you and says, they said it's not Lyme, or I can't afford to get treated, or I can't find a Lyme literate physician, what do you do? What do you do for them?
Well, I think there's a lot of things that you can do. One is you can give them literature. There's many good brochures that ILADS has produced that can lead them in the right direction to know that they have choices. Also to refer them to support groups, whether that be, if depending on their ability, if they have a hard time getting out of the house, maybe an internet support group. If they can travel, getting to like a local support group. And then, there are other organizations that do help clients make, with referrals to different doctors who are Lyme literate. So there are ways to, help them in terms of tangible results. But then there's also the notion of, well, my doctor told me I have MS. And yes, I was diagnosed with Lyme disease many years ago, but I was treated. I don't think that has anything to do with why I have MS. There's that conversation with the client about quality of life. So I think, that it's not just about giving them tangible answers. It's also about helping them to figure out what they want to do. And a lot of their control has been taken away, and helping them with making choices helps to give people back a sense of control over their life, because if a spirochete is invading your body and it's taking over, you don't have much control of your body, but you do have control over your choices. So I think that's another way that, that psychologists can help people.
And control. That's another thing too. Dr. Levin, you were talking about the controversy with ITSA and ILADS and the one way and the other way. So where does that leave the patients?
Well, it is not only the patients that are confused. It's doctors who are not trained in Lyme disease who can go online for guidelines and find totally divergent guidelines. The whole American notion of evidence-based medicine is based upon the fact that we now have the Internet, and anyone can go on the Internet from the most distant places, even if we just limit it to the United States.
Right.
And you can find out how to treat anything. But what it is the latest information from some group or organization that has been hired, if you will, by the government who runs the guidelines, and they respect the hierarchy of medicine, which is that when you are board certified, you're an expert. And so that the IDSA, which are representing the board-certified physicians in infectious disease, we believe, we being the loyal opposition, we believe that they have been trained incorrectly by the leaders of the organization. And the leaders of the organization, of course, deny it. And the conflict of interest that was brought out in the hearings was of such magnitude that the panel was disbanded and a new panel set up, and they refused to go against the previous guidelines. So everyone is in a quandary, and patients have to listen. And one of the problems, I think, that is unfair is that the IDSA does not feel that they have to tell patients there's another approach, another belief, another way. They have the right. They are the experts, and they don't discuss the alternatives of longer treatment, of multiple antibiotics. Their guidelines specifically say only one antibiotic at a time. And they ignore the evidence that this bug can undergo dramatic changes in its form and trace. It's called metamorphosis. And I learned about metamorphosis in 5th grade. My teacher brought in caterpillars, and we played with them, and then they made cocoons, and we sat and waited day after day. What's going to happen? Just wait. And out came butterflies. I could not process that. it was beyond my understanding. I was in 5th grade. I'm a lot past 5th grade. I still can't understand it. I still don't know how nature does that, what makes it happen. We can identify these things that change, but we don't understand it. And for them to ignore the fact that this is the most complicated bacteria we've ever discovered by far, and that it is suppressing the immune response of the patients to defend itself because the immune system is what's trying to kill it. They are just denying all of this and making it simple. 4 weeks of antibiotics is all you need. As a matter of fact, now they're talking about cutting it down.
Yeah. I think I would have died because in 1997 I was told by a wonderful physician that I could take doxycycline the rest of my life if I needed to.
That you could do what?
That I could take doxycycline indefinitely for the Lyme because it actually was working. But if I'd only had 4 weeks, which we tried, then we tried 6 weeks, then we tried 90 days, then we tried 6 months. We went on and on and on. And it didn't do the job. And it probably 2 antibiotics at the time would have helped. But that wasn't the protocol.
And it still is not. It is contrary to the guidelines of IDSA. If you use 2 antibiotics, you stop one and use the other.
Right,
pulsing is what they call that. Yes.
And then you have a client who says, my doctor gave me this, I'm done with my treatment, but I don't feel good. I still don't feel good, and they just don't know what to do, and just like when you were in 5th grade and you didn't understand that, somebody who is going through this and is listening to their doctor and they don't know, they're just thinking their doctor's telling them what is correct, and they're not, they don't know how to educate themselves yet. What do they do? So then they're stuck, and then they're confused, and then they feel like there's something wrong with them, and then they doubt themselves, and then they don't know if there's if they should. Then they start saying, well, maybe there isn't anything wrong, and then they. So then you're doing something then this becomes trauma in the client.
Right.
Psychological trauma.
Yes.
Yes. Well, the doctors, you guys use more than one drug to treat, for example, heart. Okay? Do you not?
I don't understand why they cannot expand their horizons. There are a number of other infectious diseases that require more than one agent, and they recognize the suppression of the immune system. HIV is, of course, the best example, and so they use multiple antibiotics and long course. That's how they get them better, but they just don't extend that to Lyme disease. I can't explain it.
Yeah, I can't. I can't even imagine it. I can't. What else are you seeing in your practice, Dr. Lipson? By the way, everyone out there, this is Dr. Mindy Beth Lipson. She's a psychologist. She's here with us tonight talking about emotional Lyme. So what else are you seeing in your practice with regards to this?
Well, I think that I see the whole gamut of different types of problems. I mean, like we talked about labels before, somebody will present as if they're bipolar, but they may have an infection, or somebody will present with, memory loss or cognitive problems, and they'll be told by their doctor it's, they're having depression or pseudo-dementia when maybe they have an infection. So I think I see a whole host of issues: obsessive-compulsive disorder, anxiety disorders.
And it destroys families. It destroys family relationships. It puts people into a financial state that is well beyond the average American's ability to handle, and then the insurance companies deny coverage on the basis of the IDSA guidelines.
Yeah.
And
I think that the family issues are so extensive in terms of what I usually notice with families is either there's this kind of complete enmeshment, so the family is all, we're going to fight Lyme together, and or the family just is unable to cope, doesn't know how to deal with the illness, will sort of, the person with Lyme, if there is one, usually there's more than one typically in a family, but let's say there was one, that person is seen as, they're causing a problem, or they're not able to kind of assist, and then there, like you had mentioned, all of the financial difficulties. And I think that it's not only that the clinicians need to be educated and the patient needs to be educated, but also family members need to understand what is happening to their spouse, what is happening to their child, what's happening to their parent, and how can they best assist them so that there isn't that, level of alienation happening.
Are you getting a lot of clinician referrals? And what I'm going to ask is, and I don't really know if you can answer this, but clinician referrals saying, okay, this person has Lyme and has emotional Lyme issues. Are you getting a lot of those?
Usually people will either come to me because they don't know what's wrong, and they're struggling with health issues that nobody can figure out, or they come to me because they already have been diagnosed with Lyme disease and they want to work with somebody who knows about Lyme, or they come for particular types of techniques that I may use, but I don't usually get referrals from clinicians in that way.
I would say that the problems of multiple practitioners being involved is another cost issue. It's very difficult for patients. The repeated visits that are necessary with the psychologist are further expenses that they can't afford.
Yes.
And I don't know how to get around that either. I certainly, after 50 years of practice, have significant skills in supporting people emotionally, but in-depth psychiatry or psychology is very difficult.
Yeah, I think that that's also part of one of the things that clinicians who are going to work with, Lyme disease patients need to understand is that it's not just, it's not just that you're taking on a client, you're going to see them once a week, like a typical client. Usually Lyme disease patients can require more time, and so there has to be an investment and an understanding that this isn't a needy client like we used to think in psychology, like this is like a borderline client or a personality disorder where they're asking for so much and we need to create boundaries, that these are clients who really have ongoing crises and they need sometimes more assistance, especially in the beginning, when they're first beginning treatment. And so that may mean, phone calls or phone therapy along with, regular in-office visits and, reducing costs for clients, working on a sliding scale, working with family members where maybe you wouldn't normally do that. You may see multiple family members. So I think it's sort of stepping outside of a traditional role of just seeing somebody once a week to kind of doing this whole type of treatment.
Wow, that's a whole other ball game now, isn't it? I mean, because most patients are used to, oh, wait, I've got a weekly appointment with my psychologist. So why is that? I mean, I know that it's presenting more problems having Lyme disease, and especially when we can't get treatment unless we do go to doctors like Dr. Levin and get the treatment that we need. And so where does the fight begin? Where do the physicians go?
Where does the physician go, you said?
Yes, where do the physicians go? I mean, is there they go to ILADS, they can get treatment guidelines there. Where else do they go? I mean, I know that LLMDs, they spend a great deal of time on the first, second, maybe even the third visit because it's such an in-depth thing that you guys have to do. You have to look at everything. And that takes a long time. We're complicated human beings here. And so should this be part of it? Because you guys, doctors, physicians, clinicians, they have lots of patients. Is this something that should be on the schedule if patients are needy, as Dr. Lipson said, or if they have, if the physician sees or hears of emotional difficulties with Lyme disease? Should this be part of the regimen, is to offer outside help, or?
Well, I think that part of it is what Dr. Levin was saying about financial. I mean, I think a lot of, Lyme patients are struggling financially. So, it has to seem like it's going to be of help. And because of the fact, like I said earlier, when early on a client is going from doctor to doctor and they're being told there's nothing wrong, or you're just, it's in your head, or you're just depressed, they don't want to hear that again. So psychology is like probably for some people at different times of the illness seen as they're just going to tell me it's in my head, when that isn't really the case, depending on who they're seeing. And again, that would go through, trying to find somebody who has an open mind. And that would be the same case with seeing a medical doctor. The best medical doctors that you could possibly see would be somebody who would want to work collaboratively with their client, learning from the client as well as, from what they know themselves and trying to get further education. So I think that there has to be, the understanding of that, so talking to a patient about going to a psychologist or to a social worker or a mental health provider has to be seen as going to be beneficial to them in some way, and not just it's in your head or you're crazy. Then I think that those stigmas that used to exist do sometimes exist for Lyme disease patients because of what's happened to them.
Right. Exactly. And I don't know how many Lyme patients out there have not been told it's all in your head. We hear that a lot. And and it might be the spirochete's up there, I'm sure.
Oh yeah, absolutely. I mean, there is the tangible thing. I mean, obviously there is a neurochemical change going on, but then there's also this, emotional, psychological trauma that's happened, and those things need to be balanced. And
plus, you have outside stressors. I mean, you may have a job that you have been there for years and don't like anymore. Had to cut. I mean, the economy is horrible. And maybe there's other stressors going on as well. And that is all hard to handle at one time, especially with Lyme disease. I do have a question about a model of mental health, Dr. Lipson. I've discussed this before with psychiatrists. One psychiatrist told me, he's from Australia, told me that there is no definite model of mental health.
I'm not sure I understand. Sorry.
Well, I mean exactly what mental health, good mental health, really is.
Yeah, absolutely. Because I think we're all, we run on a spectrum of what is normal. We really don't, I mean, there's on one end you may have psychotic behavior, at the other end you may have neurotic. Do you want to be more neurotic or do you want to be more psychotic? I think it just depends on, what's happening in your life at the time. I'm kind of making a joke, but if you're going through Lyme disease, do you want to, and nobody's listening to you, and everybody's telling you you're delusional or it's in your head, you can start to maybe think that that's the case, even if it's not. Even if there is something neurochemical happening and you are having these, maybe you're having musical hallucinations and then they've told you that it's this. but maybe it's because of an infection, but they refuse to see that. So, I mean, I think that pathology runs on a spectrum. Where are you going to fall? I think when the pathology is outweighing itself in terms of the intensity of it, that's when you need assistance. That's when it becomes too great. So is there a perfect model of mental health? Probably not. The DSM is just a series of symptoms. These symptoms mean this disease, but is it a cause? No, it's just a cluster of symptoms.
Right. Dr. Lynn, did I cut you off?
No.
Oh, okay. All right. Terrific.
I couldn't have said that better.
Yeah. Well, I want, and we try to gear this show. This is a new format. We're trying to gear it towards clinicians and other healthcare professionals. If they will just listen to their patients, correct? Just listen to them, will they not learn a great deal?
Yeah, I think listening is key, in particular for this population, for, tick-borne illness. I think believing your patient is number one also, not just listening, but believing your patient, because a lot of people haven't been believed in so long that, if you don't believe, if your patient has any feeling that you're not believing them about what's going on, that you're not going to be helpful. You have to understand and have empathy and try to learn about what the person is telling you, what has happened to them, why is this happening to them. Are there
in our field of medicine in general, we have been taught from the beginning that we should try to make a diagnosis that fits most of these symptoms the best, and the listening to the symptoms certainly is important. I don't remember which of the famous teachers said, just listen to the patient and she'll tell you what her problem is. Certainly that's a very important part of the story, the history of the patient. But with the advent in my life of environment.
Did I lose Dr. Levin again?
I think so.
I think so. Well, listen, we have a caller. Let's see if we can get them. Caller, are you there? Caller? This call was from Canada, and it doesn't seem like we have them on the air. Caller, are you there?
Oh, I don't know if I'm on the air. I just phoned in.
You are on the air. Do you have a question?
I just tuned in, so I didn't know what was going on, but I probably do. I don't know what it's all about, so it's my first time.
Oh,
but I got the number off the website, and I didn't know what you were talking about or anything, but I thought I should speak up and let you know.
Okay. Do you have Lyme disease?
No.
Oh, okay. Well, then you can learn all about it.
Oh, good. This is the first time I've been in here, and I didn't know that dialing the number would get me talking, so I'm sorry.
Oh, sure. No,
but I'm glad I found you. I'll listen.
Okay. Thank you so much for calling.
And learn. I love to learn. I'm very into health, so I'm
all right.
Here. Thank you.
Thank you. Bye-bye. Okay, well, we're going to continue on. This is a fascinating subject. Again, I hate to say that we talked before, but a lot of us patients have run into, I guess, people that they seem psychotic to us, okay, to some of us. And a lot of us, we've gone into hibernation almost. And you and I talked about this a little before, and you said that it didn't seem like it was all from Lyme. Could some of it be from Lyme?
Yeah, I mean, of course. I mean, I think that, like we were talking about before, how the spirochete invades the brain, the nervous system. Obviously it can create, profound changes, personality changes, But I think that some of the things that we were talking about earlier also sound like, pre-existing pathology more, but definitely. I mean, I think that we know that
something
to be the case.
Kind of brought, yeah. And how does one really know that? I mean, a physician's not going to spend the kind of time. Is that what you do? Spend that kind of time?
Yeah, I mean, I try to. It's sort of like a little bit like being a detective. I mean, I think you have to ask the right questions, and some of those questions may be around, what if they're age 40 and they never had any psychiatric symptoms before, and all of a sudden their personality's changing, and their husband or their wife is saying, you're raging every day, you're so irritable, you're doing all of these things that don't seem, typical to that person, then I would say, and they, go out and they're golfing or they're, doing activities where they may have been exposed to a tick, I would say, all right, let's keep asking questions. Maybe we're going in the direction of Lyme disease. If somebody had a pre-existing condition, so they already had, let's say, a history of being hospitalized for bipolar disorder, that doesn't mean that they couldn't get Lyme disease also. But I think you need to ask those questions previous. Did they have this? Also, how did they respond to medication? Sometimes when a client is being treated for psychiatric symptoms and they have Lyme disease, the psychotropic medications don't always work in the way that we would want them to work unless they were receiving antibiotics. So that's also a clue if the psychotropic medication isn't working the way you would typically see in a patient. If you continually give them antidepressant after antidepressant and it's not working, yet they're so highly depressed, you're doing in-depth psychotherapy, you're doing all the right things and nothing's shifting, then I would say, okay, ask some other questions. Maybe they've been exposed to Lyme disease. So I think that those are some ways of trying to decipher, getting a good history. Sometimes you have to talk to family members. Other people involved in the person's life.
Right, exactly. Welcome back, Dr. Levin.
Yeah.
Yeah. We keep losing you. We had a caller from Canada, and hey, by the way, glad to hear Canadians are listening. She didn't have Lyme, but she wants to learn about health, and we let her know that we're talking about Lyme disease, emotional outcome of Lyme, and it is a roller coaster. It's almost like menopause. Seriously, it is. It's 1 minute you're hot, 1 minute you're cold, 1 minute you're happy, the next minute you're in tears, and it reminds me of menopause. And that's something that I'm not so sure that I would, I don't think that I told my physician at the time that I was on a roller coaster. I thought I was absolutely losing my mind. And here it turns out to be a tick-borne disease. Once that's under control and the correct way, and it's not an overnight success, let me tell you, it doesn't happen overnight. But once that's under control, then you get out on an even keel.
I think that's also, Sue, one of the things that makes it so difficult for, when we're talking about training other clinicians to understand about Lyme disease is like to understand that the symptoms kind of wax and wane, that 1 minute you may be feeling good and then the next minute you can't remember how to turn the key to your door on your car and you're getting lost going home and, and then the next day you're doing okay and you're going for a walk. I mean, I think that's what sometimes I think make other clinicians who are trained traditionally or don't think about infection would think, oh, they're just malingering or, they don't want to work or they're just making it up. But it's just part of the disease.
Yes, it is. 1 minute my physician, one of my physicians later into the disease said he learned that I drive, but he knew that I got lost. I would sit at a stop sign one time for almost 2 hours. Didn't know my way home. Didn't know my phone number to call. I sat there for 2 hours. And so he says, I really don't want to see you driving anymore. and by all rights. But then the next day, I knew my way back around again. And doctors, physicians, clinicians, everyone needs to listen to that because it is real. It is not us losing our mind. It is the disease.
And it's very difficult to explain.
Yeah.
Yes. Yes. Well, and I think Lyme patients can explain it. One day we're fine, 1 minute we're fine, the next we're not. But it does sound like menopause, or it does sound like something else on the little diagnosis chart. You know, it's like, oh, well, you're in your 40s or 50s, so you must be going through menopause. That must be it. Or, you know, you're just, get out and get a hobby, I was told one time. I have more hobbies than I have fingers and toes.
Yeah.
Get out and get another hobby. Take a vacation. Get a different job. Are you having marital problems? Any problems with the children? Anything but what it is. And that is just a killer right there. So when patients come in, do they say, hey, I have Lyme? Do you see a lot of them come in and say, hey, I have Lyme disease?
Well, no, I don't. I do see, you know, one of the difficult things in being a doctor is the discomfort of making serious diagnoses that are going to have an impact on somebody's life.
Yes.
And so for many years when I would do tests, I would hope we didn't find cancer, and I'd hope we didn't find some kind of neurological disease. And today I am seeing people who are happy to be diagnosed with Lyme disease because at least they have an answer and there is a treatment. And they've been told that they don't have any problem, and it's all in, you know, it's a terrible thing to be in that limbo. So there are times that I hope that I'm finding Lyme disease, and I didn't feel that way when I started. I thought it was a terrible thing to do.
But then it gives them hope, because then they know. I mean, it's different because in a way, if they finally, after seeing 10 different doctors and they haven't heard, and then they see you, and then you finally help them to figure out, you know, what's really going on, it can be such a relief to feel like, oh, finally I have an answer, and now I can put my energy into getting well or working on figuring out how to get well. And before it was just, well, do people believe me? You know, I mean, I think that's the shift for them, is knowing that there is something that they can do about it.
Right. Dr. Levin, could it be, and it's not just Lyme, could it be all the other things that you're finding in a Lyme patient that could also be causing the emotional situations for a Lyme patient?
Well, I alluded to that. I think that when you come from the point of view of the infectious disease specialist, once you make the diagnosis, all you have to do is give 4 weeks of antibiotics, and that's all the patient requires. They don't have time to realize that the patient's adrenals are losing their ability to keep up with stress. And I don't know how they can ignore the patients who call up after a couple of weeks. You know, you're finished your 4 weeks, and many times people are feeling better after their 4 weeks of treatment, and then a couple weeks or a couple months go by. I was practicing in Connecticut, where Lyme disease, my little town of Wilton, Connecticut, said in 2003 that 54% of the families in Wilton had Lyme disease. Now that's a huge epidemic.
Yes.
And so I was seeing many people, and I started out using the treatment that I learned about at a weekend meeting that was sponsored by the Centers for Disease Control. So I was giving patients 4 weeks of antibiotics. And indeed, the first time I got it, that's what I did. And I got better. I was really very seriously fatigued all of a sudden. And I don't remember which antibiotic it was even, but I took 4 weeks of antibiotics and I felt better. And a year later, it came back again. And I didn't recognize a bite the first time, and I didn't recognize a bite the second time, but the blood tests were very clear. And that's when I said, wow, I better find out that somebody has to know more than this. When I started treating patients for a 4-week period, many of them would call up and say, you know, Doc, this knee is starting to act up again. Can I have some more antibiotics? It really helped. And I said, well, you know, we're not supposed to do that. They're dangerous, you know, and it's post-Lyme syndrome, and it'll be okay. Take 2 aspirin and call me in the morning. And these were people that were in my family practice. And if he called up in another week or two and said, Doc, I can't go to work, can I have some antibiotics? Like, I said, sure, let's see what happens. And that's how I found out that it worked again. And so there is a great deal difference what I see in my practice and what I'm supposed to see according to the specialists. And I believe it's because they never give it the opportunity. They are taught, don't do it, they don't do it. The patients get disgusted and they go elsewhere, so they don't see the follow-up. And if they do, I mean, suppose this young infectious disease doctor comes out of training. Well, when I came out of training, you hung up your shingle and you sat around and you twiddled your thumbs until patients came. Especially if you were a specialist, you depended on somebody else to send you patients, and it was a long time to build up a practice. Today, the specialist goes to the insurance company. He says, I'm a infectious disease specialist. Oh, well, we need one of you in Centerville. Are you willing to work at? Sure, I'll work. And he's got a practice. And the insurance companies pay for the specialist. Well, what happens if he gives the 4 weeks and the patient doesn't get better? If he has any empathy or sympathy, he tries to give some more antibiotics to see what happens. But if he does it too often, the insurance company is going to call him up and say, listen, don't you know the rules? 4 weeks is all we give. And if he disobeys, he can lose his job with the insurance. They can report him to the IDSA, and he can be given a hard time by his specialty group, and indeed, in some instances, even turned over for discipline to the state. So it is bad for the doctor to break the rules. And if he doesn't break the rules, he never sees what happens if he breaks the rules.
Right.
It's a self-fulfilling prophecy.
But if he doesn't break the rules, he's not going to treat patients. He's just going to make the insurance company happy.
Well, that's what I say. The patients will eventually go someplace else, and he does. So he assumes they got better.
And if they don't go somewhere else, then you have a whole generation of people who are going to be disabled. Because, like you said, if 54% of people in Wilton, Connecticut at that time, I mean, God knows what it is now, then
no, not people, families.
I'm sorry, families.
It's different.
But families.
Still, it's a horrendous number.
Yeah.
So I really believe that the younger practitioners do not have the opportunity to break the rules, and that's why they don't see what we see.
And the reality is, even I can tell you, obviously I'm not going to give names, but I can tell you that the clients that I work with over the years, that some of the doctors that are supposedly infectious disease will give long-term antibiotics. Even if it's not as long as maybe some of the Lyme literate doctors, they will, even though they're not supposed to. Some of them do it.
Well, it's very reassuring to hear that, and we know that indirectly because we know that there were some physicians in the IDSA who wanted to be on the panel to write the guidelines, and when they differed, when they had, they were thrown off the guideline committee.
Yeah.
So this is a tough network.
Doesn't ILADS, they have a program where they're working with physicians, correct, Dr. Levin?
Well, they have a training program. They have a few physicians that they have selected who have been in the organization for a long time, who are considered mentors, and they can go and spend a week with somebody who's doing it, and it helps them to become members in good standing and get referrals.
Right. That might be something to look into. Holistic healing techniques. What are all of the things? Because I know I was reading over your stuff here, and it says imagery, visualization. Use that. What is that, Doctor? What is that?
Well, it's using visualization to promote healing. So one of the things that we've been finding in the last, I guess, over 30 years is that, and these studies have been done particularly with people who have cancer or asthma, that when you give somebody a treatment, a traditional treatment like chemotherapy or other types of treatments for cancer, if they do imagery exercises, visualization exercises, typically around 21 days, which is the time it would take to break a habit, that they have better outcomes than clients who just get straight treatment. And so visualization is a way of, I feel like it's a way of tapping into the higher self, your higher self connected to, whatever you want to call it, universal consciousness. And in that way it helps to promote healing in the body. So it's the mind-body connection.
Yeah, I like that. Well, go ahead.
It fosters the miracle of healing. And again, I think it is very important to understand how little we know of healing, so that if you get, maybe if you have a chance, you wash your hands with soap and maybe put a Band-Aid, but whether you do or not, it's going to heal. And we can talk about exactly what happens under the microscope from animals where they make a slice with a scalpel, and then they just look every few hours to see what's happening.
Mm-hmm.
And what happens is it heals usually without a scar. But we don't understand that. We don't know how to identify what happens. All we can do is say healing is part of the program that you're born with, and it's part of your birthright, And what Mindy is saying is that it is affected by consciousness. So that if you make an effort to heal and visualize this healing process, and visualization is, you can say, I want more white blood cells to come to this infection and get rid of it. Well, you can imagine the white blood cells as clouds or as knights on white horses with lances or whatever. The body understands what you're saying. And I had a personal healing experience that I think is a great example. So over 20 years ago, I learned that I had a cancer of the kidney. It was a long, involved story to get there, but this thing was the size of a small grapefruit. And it had to be surgically removed. And once I heard about it, we set the date for the surgery, and it was 3 weeks later so that I could give a couple units of blood in case I needed a transfusion. And I went home on the commuter train from New York to Connecticut, and I did a meditation that I had been taught by my spiritual guru. And I got down into my meditative state, and I called my consciousness on the carpet, and I said, you have really messed up. Now here's what I want you to do. And I said, I'm going to lose this kidney in 3 weeks. I want to turn off the blood supply to my kidney, to that tumor, so that it doesn't have a chance to grow anymore. And I did that in this noisy train, and I did it once, and the day before the surgery, they took me down in the hospital to the radiology department to do an angiogram, because the kidney's blood supply is different in everybody, and they need to know where these blood vessels are so that the surgeon doesn't go, oops, and have a problem. So I went down, they put the catheter in my groin and snaked it up, and they put the dye in to see where the arteries went. And the guy said, that's strange. I said, what's strange? I'm looking at the monitor. I didn't know what the hell I was looking at. And he says, well, it says that you have a cancer. He says, I see the tumor. There's a large tumor. But he says, I don't think it's cancer. I said, why not? I had an ultrasound, and the ultrasound said it's not a cyst, and if it's a solid tumor, then it's supposed to be a cancer. And I thought, why don't you think it's cancer? He says, it doesn't have any blood supply. I said, well, I've been working on that for 19 days.
Wow.
And he didn't understand. And so I had told the surgeon when I left his office with the diagnosis that he better hurry up and get this out, because if he didn't, it was going to be all dead and shriveled up. So when I woke up from surgery, the surgeon was standing there, and he said, how you feel? I said, I don't know. I haven't been awake long enough. He said, well, I want to tell you, I took that kidney on the table and I cut it open, and it was all necrotic. That tumor was all necrotic. Necrotic is dead. Uh-huh. But it wasn't shriveled up. And,
good for you.
The radiologist reported that this is an avascular tumor. And I think that was a miracle, and I think I had something to do with it. So that I am very much a believer that healing is something far beyond our understanding. and I am certainly blessed to still be here. And I haven't been successful with less serious stuff, but when the chips were down, boy, it really worked.
How long has that been around, Dr. Lipson, that technique?
Oh, well, it's probably been around for hundreds of years, I would gather. But in psychology, it's been used for, I don't know, maybe 60 or 70 years. Probably.
Wow.
People have been using it in spiritual practice for probably hundreds of years. So, or maybe
Sounds
even
like
longer than, maybe
medicine.
longer. Probably longer
Yeah.
than that. Yeah.
Right. And biofeedback. Tell me a little bit about that. Just for some of our listeners out there, because we have quite a few people in the chat room right now, and they might not know what biofeedback is or what it can do for them.
Well, the type of biofeedback, well, I do several different types in the office, but the one that I'm getting into more and more now is EEG neurofeedback, which is basically it's a way of working with the brainwaves. So like if somebody's having anxiety or attentional issues, like let's say they have problems with focus, or they have anger issues, or they have depression, you can work with various parts of the brain. Also pain, headaches can be treated with it as well. So you're working with different sensors on the scalp. And you can work with, the parietal, you can work with the frontal lobe, you can work with the somatosensory cortex, and you're basically helping. When you're working with the brain waves, you're increasing neurotransmitters, so it can help your mood and your focus and your cognitive functioning, your level of pain. So we look for a regulated brainwave map, which would, it has a certain look to it. And when people are having, post-traumatic stress disorder, anxiety, or attentional issues, their brainwave map will look a little bit different, and we want to work to regulate it. And over time, with certain amount of sessions, people can improve their, those types of symptoms.
Now, I have a question.
The point is that the technology has enabled us to allow the patient to observe the results of what it is he's doing. If he holds his breath, his heart rate changes, maybe his brain waves change in a certain place. If he breathes rapidly, other changes happen. So you teach him, this is the change we want to see. Relax, let's see what happens. Oh,
yeah, so
look, it's getting better. Well, what did I do? I don't just do what you were doing. And that allows this process to become a intended process rather than just it's the feedback from the instrument that tells you you're doing it right that helps the patient to do it better.
Yeah, and how they're getting feedback, too, just so people can kind of visualize it, is as they're hooked up with these sensors for EEG neurofeedback, and also the other one that you were mentioning is heart rate variability. But for neurofeedback, you may be looking at a computer screen, and let's say you have a picture, and as you're breathing and your brain waves are getting into what we call the zone, or the area where we want them to, whether you're inhibiting your theta, if your theta is too high and we want to reduce that, or we want to increase your beta because you're depressed, as those waves are getting into the correct pattern and you're being rewarded for that, something on the screen will change. So let's say you're looking at a picture of like a nature scene, it'll kind of move to another scene and then another scene. Or if you're making flowers bloom, the flowers will grow. But you're basically, the feedback of your own brain is making that happen as you're doing what you're supposed to.
Does an infection interfere with the biofeedback?
Does it interfere? I think that the biofeedback will help with the infection because it's helping the brain to function more optimally.
Well, the first biofeedback technique that I learned was to increase the temperature in the hands. I had cold hands, and it was supposed to be related to a tendency to high blood pressure. So they hooked me up with a sensor on my fingertip that was a very sensitive thermometer. And it registered the actual temperature of the finger. And it also induced the sound from a sound generator. And as the temperature increased, the sound level increased. So it went, and I happened to have an absolutely beautiful woman as the technician, and she spoke very slow, gentle, soothing phrases, and I relaxed, and as I relaxed, the circulation to my hands increased. And I learned how to do that in 10 or 12 sessions so that I could change it just by thinking about it.
Yeah.
And it was the sound of the instrument going up and up that allowed me to learn that I was doing the right thing. And it's still a very common biofeedback technique for people who are in high stress and hypertensive.
Wow. I didn't even fully understand until now. That's awesome. Well, also you say, Dr. Lipson, a spiritual practice. What does that entail?
Well, a whole host of things, but I think typically what I'm referring to is kind of, at least, and let's talk about it in terms of Lyme disease or tick-borne infection, is that people, need to have some sort of an existential understanding or a spiritual meaning for what's happening, because they've been going through so much, and sometimes people don't want to continue. I think that the feeling of suicidality is somewhat common amongst Lyme disease patients at various times, and I think that having a sense of their spiritual nature, that they're more than just their body, that they have this mind-body connection, the spiritual connection, helps them to feel better about what's happening and to make meaning out of their life and out of what's happened. And I think that that's one of the most important things that you can do, besides believing the patient, is helping them to create meaning out of what's, happening.
Right. Yeah, because it would be pretty bad if all this was happening for no reason or whatever at all. Yes. Just having a bad day.
Religion is such a controversial thing in our world, but in terms of people being comfortable with their condition, a belief in some sort of God is as good a word as I can come up with, but some power that is responsible instead of the individual being totally responsible for whatever happens, that provides great comfort. People can say, well, if God wills it, then that's the way it's got to be. Whatever God's will is best. They are much more comfortable, in my experience, than the atheists who basically say I'm responsible for this, and if I'm not getting better, I'm failing.
I think even if people don't believe in God, that there can be this sort of, greater sense of connection with other things, whether they want to believe that they're a part of the earth or nature or something.
Well, I used God as a broad concept.
Yeah.
The idea is that we are not totally responsible for what happens to us.
Yeah, of course. So that meaning can be made out of anything, that people can relate to. So if they're an atheist, they can still find meaning in, what's happening around them, or what this is all meaning to them. And the meaning for them may be different than for somebody else. But I think when we help people to try to make sense of that, and what does it mean for them, and not having an agenda like this is what, me as the therapist thinks, but what do you feel, and where is this coming from for you, and what are you learning out of this, and how are you growing? I think that it helps the healing process.
I am sure that's true.
We have a question.
It is just more difficult when you're working with someone who doesn't have a I don't mean religion either. I'm just speaking of an awareness that there's something besides self that is responsible for what's going on.
Right.
The famous Carl Jung had a sign above the entrance to his office, and I copied it and put it over mine. It's a Latin statement. It says, "Vocatus sive, non vocatus Deus aderit," and it's translated, "God will be present whether called in or not."
That's true. That's cute. I like that.
And so I believe that, and I tell patients that, we just have to call upon the source of energy and life within us. That's part of what makes us alive. And as long as we have that, we can harness that energy and focus it.
That's the collective unconscious.
Okay.
I have a question from the chat room. I'm not really sure I understand it, but I'll read it word for word. Do you think there really is a power above us, or is this just believe it, whether it's true or not, and you will benefit? Is it all a matter of chemicals?
I must have missed the word. Would you repeat that?
Sure. Do you think there really is a power above us, or is this all just believe it, whether it's true or not, you will benefit? Is it all a matter of chemicals?
Well, I do think it can be boiled down in our understanding to chemicals, but who created the chemicals and who created, we don't understand this. And as long as we don't understand, it becomes necessary to believe something made this happen, this whole incredible thing. It is not possible for it to be a coincidence.
Right.
So,
I would say that if the caller has Lyme disease, that whatever the answer is what they want to make the meaning out of it. So if it's that it helps them to understand that something in their, in their own body is making something happen for them, or if it's that they're looking outside for something greater, it's really it's sort of a personal feeling and a personal meaning. So, if they want to go further than just what's happening in the body, then they can, and if they feel like that can help them make meaning, just looking at the body process, then I would just turn the question back to them.
I think it's really important to understand that the people who get better are the people who are healthier to begin with. And our society is an increasingly sick society as a result of the failure of the powers that be to ensure that our food supply is of the highest quality and our water supply is clean and our air is pure. Individuals have to take responsibility about what goes into their bodies. If they are sick, it's even more important that everything be supportive and not detrimental. So you have to stop eating junk food, and you have to stop drinking diet sodas, and you have to give your body the chemicals that it requires. It is a chemically run machine, and we are poisoning it with all sorts of horrendous stuff.
I agree. And alternative medicine, that offers us a lot more than pharmaceuticals, I believe. It's my opinion.
Well, if you exclude herbs from pharmaceuticals, then that's true. But most of the pharmaceuticals for most of my practicing career came from herbs. Right. Now we're manufacturing these foreign chemicals, and I think it is a problem.
It is a problem.
I think that most, clients that I've seen over the years that tend to do the best are the ones that try multiple modalities. So, whether they've done, long-term antibiotics and then they've done, herbal remedies and minerals and massage therapy and, energy medicine and, biofeedback and all other sorts of, alternative treatments, hyperbaric oxygen. I mean, I think people benefit from all of those things, and they do better. They have better outcomes.
But what works for one may not work for another.
Yeah.
And that's what I think ITSA has forgotten. I really do. I think they have forgotten that. What maybe an antibiotic, a certain antibiotic, doxycycline doesn't work for me. My drug of choice is Biaxin. But doxycycline might work for another Lyme patient, and gosh only knows how long that will take, but they have forgotten that one pill for all your ills just doesn't work. And it doesn't work on most people. Yeah, you feel a little better after 3-4 weeks, 6 weeks on the antibiotics, but firsthand experience tells me when you come off of it, you're only going to feel good for a little while, and then you're going to go right back in if you take the one medication for the 4 to 6 weeks. And that's firsthand. Dr. Levin, you've seen that in your practice?
I certainly don't find one formula that works for everybody.
Right.
And, I think it's not just hit or miss. There are different stages of the illness. The organism apparently is able to hide within the tissues of the body, and that makes a previously effective medication ineffective. And there are all sorts of other possible explanations for failure, and it is constantly listening to the patient's report of what happens. At the beginning, I worry if patients don't feel worse when we start treatment. It's
right.
called a Herxheimer reaction. You don't have to have it, but when it happens, it suggests that the medication is working. And that's temporarily good news.
Right.
So I tell patients they don't have to have it, but not to feel bad if they do, because it is an indication things are getting better.
Yeah, that's like reframing it for them so that they, a lot of times people just think when they take medication that you're just supposed to feel better, and with Lyme it doesn't work like that. So I think for people it can be somewhat discouraging when they're not feeling well, but to reframe it and help them to understand that this is actually a good thing. This means that you're on the road to getting better. So I think you have to help people to reframe that also.
Yes, it does help. Dr. Levin just said a word, stages. We have different stages of Lyme disease. Have you seen or experienced stages of emotional Lyme disease? Any kind of patterns or?
I have, and when my book comes out, if that ever comes out, it'll be in there. But I will say that it is sort of similar to some of the stages of grief and loss. And so there is, some of the patterns are similar, and then there are some things that are a little bit different. And that is because of the nature of some of the things that we've been talking about in terms of the controversy and the extra stressors that people have to go through, and sometimes the ongoing nature of the illness, the chronicity, relapsing, remitting nature of the disease. So I think that, it's a little bit different, but some of the stages are similar. People go through denial, a lot of depression, bargaining, so a lot of those symptoms are the same as what you would see in other illnesses, whether they're going to die from them or they're going to continue to live. And so with Lyme, there's slightly different patterns.
Right. Well, with Lyme, sometimes you don't know whether you want to live or not. So on this different stages of the emotional Lyme, are there different therapies, psychological therapies for those things, the different stages?
I don't know if there's different therapies. I mean, I think each clinician is going to work from how they were trained, and I think, cognitive behavioral therapy can work well, psychodynamic therapy can work well, psychospiritual therapy can work, people who are from an existential perspective. So, I mean, I think all of those treatments can help people through the different stages that they're going to, go through, but I don't think that there's one that's better than the other. I think it just depends on the clinician. And what their preference is, and also what the patient's preference is,
and what the patient's illness is.
Yes.
Yeah. Yeah. And see, and this looks at the whole patient, correct, Dr. Lipson? You look at the whole patient, the illness, the stressors, everything going on with them, correct?
Yeah, it's really, every facet of their life, their social, their work, their family, their community, their physical health, their emotional health, their spiritual health. It's sort of everything all together and how those things are working. So it's how the macrocosm of the world and their own microcosm of their own family community is affecting them.
And again, I want to emphasize that one of the most overlooked pieces of this puzzle is environment. And the environment, in great part, is beyond our control, but there is also a great deal that we can do about the environment. And for many years in preventive medicine, we were saying to people, eat the right food, don't eat the wrong food, exercise, get plenty of rest, take supplements, and do something for psychospiritual equanimity. Well, all of that is the environment that is being modified. And it wasn't until 2001 when they made this grand announcement in December of 2001 that the mapping of the human genome was complete, that we had a way to observe the effect of the genes and the environment. And to me, the most important lesson that came out of that discovery is very clearly the genes are not totally responsible in most cases for the outcome of their expression, because they work in conjunction with an environment. And when you change the environment, you change the outcome without changing the genes.
Yeah. That's why have you, I'm assuming you know this, Dr. Bruce Lipton, Wisdom of Our Cells. It's like one of my favorite books. He's just a tremendous force in terms of understanding that.
Book.
Yeah, it's just an amazing.
And again, the name is?
Wisdom of Our Cells by Bruce Lipton.
Wisdom of Our Cells. Okay.
And it really, to me, from a from a perspective of psychology, I mean, it's really about that mind-body connection that we have we can change the expression of what's happening in our body through, however you want to do it, through spiritual practice, hypnotherapy, these different techniques, EMDR, Psych K, all of these different energy psychology type of treatments.
Right. I have another question from the chat room. It says, can you suggest a DVD for meditating or to teach how to visualize and meditate? Many don't know how.
Yeah, I can give two things. One is a spiritual book, or a spiritual guru, I guess. He's passed away now, but he wrote many, many amazing books, and he gives examples of how to do different types of meditations depending on what type of person you are. And so he defines what that means in his books is Osho, O-S-H-O. I really love him. And the other one would be Dr. Gerald Epstein. He's written several guided imagery books. I believe one of them is called Healing Visualizations. And there's a lot of really good ones in there that you can take some of those and you can adapt them to, like if you have Lyme disease, you can adapt them to the type of issues that you're having. And he gives examples of how to make your own imagery in the book.
Oh,
I was privileged to have him as one of my mentors.
Yeah, I've studied with him too. He's phenomenal.
Great information. And do you, Dr. Lipson, do you teach people how to visualize and meditate in your practice?
I teach them visualization, and I usually give them some books to read for meditation or some, different CDs. And sometimes I'll make some CDs for people to help them with that.
There's another technique that wasn't mentioned that I think is very important, and that is the use of affirmations. When we think bad thoughts, we have an impact on ourselves. And when we think good thoughts, that also has an impact. What makes it more specific is actually stating these things. If you believe that it was the Word of God that was creation, we create with our words our reality. So if we use positive thoughts and state them repeatedly, we change the way we think.
Yeah, that's so true, and I think that's one of the ways that psychotherapy is so helpful for people is that it helps to look at patterns of negative thinking and negative belief patterns that people have, and how do they, like maybe, you were told over and over, let's say you lived in an abusive home and you were told over and over something that about yourself, and that has become part of your negative thinking, that you believe that about yourself unconsciously. And so psychotherapy can help you to sort of look at those patterns and help you to see how destructive they are, and then assist you with, changing the unconscious voices basically that you're hearing over and over. So to put more of these positive affirmations in place, instead of hearing that same negative, now you'll hear that positive statement, and it does change the environment, and that can affect the environment that you're talking about, can affect your body functioning and the quality of life that you're having.
So Louise Hay has a number of books that teach people how to have positive affirmations. And it is a matter of getting down and doing it. It's one of the things that can affect your view of life, and the impact can be tremendous.
I am answering questions and stuff in the chat room and in private here. Seems like people really, really, really want this kind of help, because I think in conjunction with a good physician, I think it's a win-win situation. I really do. We have about 3.5 minutes left. Dr. Lipson, what else do you want to leave our clinicians other healthcare professionals, and patients that are listening? What would you like to leave them with?
Well, I mean, I don't know. That's a big question. I guess I would try to leave people who are dealing with tick-borne illnesses with the idea that, A, they're not alone, even if they feel they're alone, that there are people out there that do want to help them and that would be willing to help them, and that there are support groups around the country that can assist them if they feel like they don't know what to do. There are many good support groups that they could go to that would lead them in the right direction of getting help, and that even if they feel like they've been sick for so long that nothing's going to help them, there are always answers. And for clinicians, I would just say probably that, just like with anything you do, you always have to be learning all the time, and we don't have all the answers, and to think that we do is problematic, and so we always need to be learning, and we can learn a lot from our clients, and we should be listening to them more and not just assuming based on symptoms, that we should be really asking the right questions and learning from other colleagues about what they're doing and how that, those things are, helping their clients in terms of like dealing with infections, and not just assuming that patients have labels just depression or just bipolar or just that there may be something else going on, and they should be considering those things.
Right.
And I think a good doctor is supposed to be listening to his patients and taking their wishes and desires into the equation, so that if you're going to do that as a patient, you need to be educating yourself so that you're not making silly suggestions. And there are a number of books now coming out. I just learned about one written by Dr. Steve Harris, and a collaborator interviewed 13 Lyme specialists, and each one talked about the things that they did. And I think it sounds like a great way for doctors to learn and for patients to learn.
Right. Well, we're almost out of time. One last thing. OSHA was O-S-H-O? Dr.
Yeah, O-S-H-O.
O-S-H-O. And Lyme literate medical doctors suggested TM, but no suggestions given.
Suggested what?
LLMD, which would be Dr. Levin, suggested TM. I'm going to say that's treatment, but no suggestions given. Maybe we could do a follow-up, and we can get those questions answered, because it looks like we're about out of time.
I found the name of the book I was talking. It's Insights into Lyme Disease Treatment. 13 Lyme literate healthcare practitioners share their healing strategies, by Stephen Harris, MD.
Stephen Harris. Thank you so much for being here, everyone, tonight. Thank everyone in the guest or in the chat room for being here. We've had quite a few in the chat room. And I am glad that we are back on the air. I'm so happy that both of you are here tonight. Dr. Levin will be with us every week on Sunday, 7 to 9. Thank you so much, and good night, everyone.
Good night, and blessings to everybody.
Thank you so much.
All right. Thank you, Dr. Lipson.
Thank you.
Good night.
Good night.